Good afternoon, everyone. My
Good
name is
afternoon.
Good afternoon. My name is Xiomara Ellis. I am an assistant project manager here at Voices for Prevention, and I am excited to welcome you all to our webinar today with suicide prevention within communities, diverse communities. Before we jump into the webinar, I still see a lot of people still coming in. I wanted to give an opportunity to introduce all of our Voices for Prevention staff here on the call today. So without further ado, I see Greg here. So Greg, would you like to introduce yourself? Oh, Greg, you're still muted.
I know that's kind of like watching a silent movie, so sorry about that. I'm Dr. Greg Raduca, and I'm the program director for Voices for Prevention and director of prevention intervention with the Council on Alcohol and Drugs. And just want to thank Esther and Xiomara and Marcio for all they do, which is a lot for Voices for Prevention, and very much looking forward to being on this webinar today with all of you. Thank you so much for joining us.
Awesome. All right. And I do see Takoya there. Would you like to say hello? Oh, Takoya, okay, there you go.
Hey everyone, I'm Takoya Garrett. I work with the Council on Alcohol and Drugs in Region 1, and just glad to be here and see this awesome webinar that Zamara and Esther and Greg and everyone put together. Just glad to be here.
Okay. Thank you. And I also wanted to briefly introduce Marcio. He is online here as well. He's part of our Voices for Prevention staff. He does all things technology, which we need greatly within COVID times. So we thank him for that and all the work that he does. We also have Esther Lopez here on the call. She is the project manager for Voices for Prevention. And I'm excited for everyone to be online today. Before we jump into the webinar, I did want to make some brief announcements. Voices for Prevention will be having their next member call August 20th. So if you are not already a member or if you have not already registered, we greatly encourage you to go to our website, www.v4pga.org, and click that registration button so you can get all the notifications for upcoming webinars and events coming. For next month, the Suicide Prevention Month, we have a lot of activities coming, a lot of different giveaways and excited events. So we encourage you all to definitely, if you're not already, following us on social media, where we will be announcing weekly what will be happening when we're having a new event, when we're having a new webinar. So we are on all major platforms, Instagram, Twitter, as well as Facebook at V4PGA. So if you are not already following us, definitely check that out so you can get all of our new announcements. Today, in our webinar, we'll be discussing suicide prevention within communities of color and LGBT community. Our guest speaker today is Dr. Sherry Molock, and she has done some amazing work within diverse communities, and I'm really excited for you guys to hear her presentation today. So without further ado, Dr. Sherry Molock.
Good afternoon to all of you all, and thank you so much for inviting me. A special shout out to Marcio in the background and to Xiomara for inviting me to present today. I'm in George Washington University in the Washington, D.C. area. I'm actually at home, but I work at George Washington University. I've been a professor there for 23 years, and I've been doing suicide prevention research for 26 years. It's 26 years this year. I started doing it in 1994. I should remember that because that's how old my youngest daughter is. So I remember the year of her birth. So I'm going to go ahead and get started. What we're going to do is we're going to do a presentation, and we're going to ask you to hold your questions till the end, and we'll allow for questions at the end of the presentation. You can put your questions in the chat or in the Q&A section. So before I present, I always like to say that we all bring with us our own background, our own context. And so I always like to share mine because it informs my work. So I am, as I said earlier, an associate professor of psychology at George Washington University. So somewhere on here it looks like I'm teaching something. And I'm also the proud wife of my husband, Guy Molock Jr. We've been married for 34 years this year. I'm also a dog lover. So this is my oldest dog, Callie, who's 10, and my youngest dog, Flirt, who is 3. We always get rescue dogs, so they both rescue. She's a golden retriever, and Flirt is a German pinscher, our first and probably last one. I'm also, my husband and I co-pastor a church together. It's Beloved Community Church, so this is us at our church. I'm a proud grandmother of 2. This is Olia, who is 2, almost 3, and this is Michaela, who is 7. My favorite TV show is The Wire. I love citron tea. This is me being a therapist. My favorite food is a combination of soul food and Thai food. I can eat Thai food every day. I do needlepoint to relax. In addition to, this is me teaching. So I teach at the university. I teach undergraduate and doctoral students in the clinical community psychology program. I'm the proud mother of 3 young adult children. This is my oldest daughter, Amber, who will be 30 soon. This is a picture of my husband. My youngest daughter, Diara, is 25, and my son in the middle is 27. That's Jelani. This is my dad, who I love very dearly. He's 94 years old, going strong. And this is him kissing our oldest granddaughter when she was about 4 years old. And so, and this is my youngest daughter. She used to teach school in Korea. She just came home in February and is applying for graduate studies in global studies. So that's all of who I am. Why am I sharing all that with you? Because all of that informs the work that I do. My research focuses on suicide prevention in African American youth and faith communities. So I combine the psychology with the faith community. Certainly, as the mother of 3 young adult children, which is the age group that I work with in addition to adolescents, I'm very sensitized to some of the things and issues and concerns and mental health challenges that young people have. And certainly as a grandmother, I'm also very aware of how these things impact families. So I don't know if you all are aware, last year, at the end of the year, the Congressional Black Caucus sounded the alarm that there was a crisis of Black youth suicide in America. Pardon me, this was in response to a report that came out in a journal that the suicide rates had really escalated in children under the age of 12. And so myself and another group of several researchers worked on that task force. We worked on what's called the work group for the task force. So this was one of their program announcements. And also this is from the Trevor Project, which I know many of you are familiar with. And it's a campaign they have going on right now, which says, I'm glad I failed suicide because my life is amazing right now. And this is just to show you that there are national groups that are aware of the suicide rates being precipitously going up, particularly in the Black community, and that people are working on these efforts now, as I'm sure you all are too. So today we're going to talk about a little bit about the epidemiology of suicide in communities of color and in the LGBTQ youth, risk and protective factors for both groups. I'm going to talk a little bit about the impact of COVID-19 and the highlight of racial injustice that's going on in the country right now, approaches to interventions, and just give you an example, if we have time, of what you can do for prevention efforts in a faith community. Okay, some of this is probably information you already know, but suicide is the second leading cause of death for youth ages 10 through 19. The suicide attempts rose by 73%, which is very alarming, between 1991 and 2017 for Black adolescents. And while the injury by attempt rose 122% for Black adolescent boys during the same time period. Suicide rates for children under the age of 12, as I said earlier, approximately double that for white children of a similar age. This is the first time in history that's ever been true. These are just some graphics about this information I just shared with you. So we know that when the CDC does a survey every 2 years, a youth risk behaviors survey. It goes to about 38 different cities across the country, and they ask youth a series of questions, not just about suicide and mental health, but also about other safety behaviors. So this is the data that we tend to look at to see whether or not suicide rates are going up or down or staying stable. And so you can see here that typically females are almost twice as likely to report feeling sad or hopeless in the last 2 weeks, that the differences between the grades are about the same. And if you look here, you'll notice that for Hispanic youth are significantly more likely to say that they're feeling sad or blue most of the time for the last 2 weeks when compared to whites and also compared to African Americans. This is asking students who thought about seriously considered attempting suicide. Again, you'll notice that the rates for females is about twice that of males, and that's true almost across the entire age group. The differences between grades are about the same. And here you'll notice that Blacks are significantly less likely to say that they are seriously thinking about suicide. I want you to remember that figure because you'll see a reversal with attempts, and that's some cause for a particular alarm for Black youth. So when you look at attempts, you'll notice that freshmen and sophomores are much more likely to make an attempt than juniors and seniors in high school. Females, again, are significantly more likely to make attempts compared to males. But look at this figure for Black youth. And so now you see the reversal from what the previous slide, they had the lowest rates for suicide, what we call suicide intent, but they had the highest rates for suicide attempts. The reason why we're really concerned about that is it suggests that Black youth are less likely to verbalize that they have a plan. And we know from other research that they're actually more likely to deny that they're thinking of suicide, even in the middle of a suicide crisis. And so that suggests that we need to ask questions differently for Black youth, because particularly even in an emergency, they may not acknowledge or appreciate that the things that they're thinking about could result in suicide. We also know that suicide rates are really escalating in the LGBTQ youth, and I'm just going to be calling that for an acronym, sexual minority youth. 40% of LGBTQ youth seriously considered suicide, attempting suicide in the last year. More than 50% of transgender and non-binary youth have considered suicide. 1 in 3 LGBTQ youth report being physically threatened or harmed in their lifetime due to their LGBTQ identity. 29% of sexual minority youth have experienced homelessness. 86% of LGBTQ youth have said that the recent political climate we're living in have negatively impacted their well-being. This information comes from the Trevor Project. There for 2 years in a row now, they do a national survey. It is the largest data set of LGBTQ youth in the country. And I have that listed as a resource at the end of the presentation. Please take advantage of that. It's amazing that they were able to collect this information on youth, and it helps you to develop programming and set policy based on this information. So it's a really good wealth of information. This is just some pictorial examples of that same information. Notice that compared to heterosexual youth, sexual minority youth are much more likely to report almost 3 times feeling sad or hopeless in the last 2 weeks. Okay, this is based on the CDC data. Seriously considering attempting suicide in the past year, you will see again lesbian and gay or bisexual youth have really escalated rates. Youth who are questioning, also much more elevated than heterosexual youth. And this has been, this data over here looks at youth gender or of sexual contacts. So the youth who have same-sex or both sex sexual contacts, which would be bisexuality, have really also really high rates of considering attempting suicide. And then sexual minority youth also make many more attempts. Those who have same-sex or both sex partners have a lot more attempts as well. So this data, I don't know about you, but it's alarming to me because it suggests that, 1, that the suicide rates are going up in the Black community. 2, that Black youth are less likely to report thinking about having either thinking about making a serious attempt or having suicidal thoughts, and that sexual minority youth overwhelmingly are at high risk for suicide, whether it's suicidal thoughts, suicide intent, or actually making an attempt. I just want to share a little bit too with you about this. This is just some of the reasons why LGBTQ youth might be at risk. We see that they're much more likely to be exposed to physical violence during dating. They're much more likely to experience violence and sexual violence while they're dating. They're more likely to be bullied at school. See, it's 33% versus 17% for heterosexual youth. And again, looking at sexual context, same or different sex context, 35%. Illicit drug use, and so we know that LGBTQ youth probably in the way of trying to self-medicate, and also questioning youth are much more likely to engage in illicit drug use than heterosexual peers. So it tells us also that the intersectionality of sexual minority youth in communities of color may be at even increased risk. There's not a lot of research that disaggregates the data so that you can look at youth from communities of color who are also sexual minorities. But in one study, sexual minority adolescents comprised less than 10% of the sample, but accounted for 67% of self-harm cases and 79% of the total youth suicide attempts. And then the rates for suicide attempts are higher for LGBT college students from communities of color than for heterosexual white students or students from communities of color. So this suggests that the few research efforts that have been made in this area, and there needs to be a lot more, suggests that the intersectionality of being a sexual minority and from community of color increases your risk further. So I want to spend a few minutes talking about risk factors. Risk factors are characteristics that increase the likelihood that youth will develop a problem behavior. It's also important to notice that risk factors are not static, so they can change over time. And we know that if you have a family history of suicide, history of depression or other mental health challenges, incarceration, the school to prison pipeline, we know that minority youth are much more likely to be imprisoned when compared to the majority culture group who are, for the same behavior, are more likely to receive mental health treatment. Easy access to lethal means, ETOH is alcohol or drug use, exposure to suicidal behaviors of others. This is really important. Sometimes, particularly if youth are aware of other youth who have completed suicide, and people talk about that suicide in a way that what we call romanticizes it or glamorizes it, then sometimes you have what's called copycat suicides, and that's almost a unique phenomenon amongst youth. You don't usually see that with middle-aged or older adults where you see the modeling or copycat effects. So it's not to say that we shouldn't discuss suicides amongst youth, but we need to watch the way that we convey that information to young people. Residential mobility, being a sexual minority, the stigma associated with suicide or mental health challenges, loss, which can be due to relationships, social losses, work, or finances, and exposure to racial, sexual discrimination and trauma. So some cultural differences in risk factors. We know that from amongst Asian communities, loss of faith can lead to suicidal thoughts. We know that school problems are more common precipitant for Asian and Pacific Island students. We know that cultural distress is a risk factor for Latinx students, and we're experiencing racial discrimination places African American youth at risk. Okay, protective factors are characteristics that help youth adapt to different levels of hardship. Whenever we talk about protective factors, implicit in that is that there are risk factors present or that these are children who are relatively vulnerable for mental health challenges. And so we're looking for factors that can help to mitigate or buffer against the risk factor. So there are lots of protective factors. It's easier to think about them if you think about them in groups. So one would be strong family support. There is some evidence that family support is more helpful, or that Black youth rely more on family support than peer support. Religious and spiritual engagement is important. Community or social support. Personal factors like positive self-esteem, having self-efficacy, emotional well-being, and factors that's coming as having stable housing, income, and employment. I want to put a pin right here just because one of the things that I share with my graduate students is that if we had treatment that was evidence-based and we had a clinic on every corner, if we don't stabilize young people's housing, their financial situation, and the employment of either them or their family, then all of those clinics aren't going to make a difference, because having housing instability and food insecurity creates enormous amounts of stress. It also creates opportunities for students, for young people sometimes to engage in behavior which can get them, unfortunately, incarcerated as a way for them to just survive. So having policies set that guarantee housing and food security for all families is really, really important and could significantly decrease mental health challenges, not just for youth, but for adults as well. Protective factors for LGBTQ youth, affirming gender identity, particularly in transgender, non-binary youth. What do I mean by that? Having their pronouns respected. I know that sometimes older adults feel like it's too much to try to figure out what pronouns to use, but it's kind of like what I liken it to is in the Black community. When I was a little girl, we were colored, and then we became Negroes, and then we became Afro-Americans, and then we became Black, then we became African American. And some people might think, like, when are you all going to decide what you want to be called? But every community has the right to decide how they want to self-identify. And however many times that changes, people have the right to be respected and to have people respect those different genders. So in school, we always ask students what they would prefer their gender, their pronouns to be. Students can either send me a note about it, they can shoot me an email about it. And I also generically tend to use they, their, and that way it would cover everybody. You can having access to binders, shapewear, and gender-affirming clothing is very protective. Having high levels of support from at least one in-person affirming space. And even though we have gay straight alliances in school, that may not be enough, particularly for students who are from community of color, because they are less likely to feel comfortable joining or being seen in those spaces. And so creating a space in your community health center and your Boys and Girls Club and your church, your synagogue, your mosque, and your school system is really, really important. And then having high levels of support from at least one person. And this data is also from the Trevor Foundation, Trevor Project. Okay, so what all of these protective factors have in common is they support and promote a sense of connectedness and a concept that I really love called mattering. Mattering is not that people tolerate you, or not even that people accept you, but that people celebrate you. That means that you're acknowledged by others. You have a sense that people care about you. They're concerned about your well-being. They miss you when you're not there. They ask about you and inquire about you when you're not there, so that you make a difference in someone else's life. And so that is a really important thing to provide for all children, but particularly for kids who are vulnerable or at risk for suicide. Like risk factors, relationships amongst protective factors are also complex. I'm sure when I mentioned religious involvement that some of you balked by that and said churches, particularly Black churches, tend to be homophobic. That is true. But it's also true that, and I'm going to talk about this later on, is that there are more and more churches that are more affirming of gay youth, 1 and 2. The mechanisms for the protective role of religious is complex. So one of the ways that religious communities are helpful and protective is that they provide support and connectedness. One of the ways that they can be challenging is if there are cultural or religious prohibitions against suicide, sometimes against seeking mental health care, and sometimes against being a member of a sexual minority group. So it doesn't mean that we can't do work in religious communities, but it does mean that we have to think carefully about how can we make sure that we increase the protective factors and decrease those things that increase risk. Okay, so let me say a little bit about COVID-19, because I get asked this question a lot, and the focus on racial and social injustice. So first, let me say that for people who live in communities of color, racial and social injustice is not new. It is being highlighted right now. But the Black Lives Matter movement has been around for a while. There have been movements before that. So in that sense, while there's a focus on racial injustice, it's not new to people who live in that community. Secondly, it's too soon to tell about the impact of COVID-19. When we do statistics on suicide and suicide attempts and thoughts, there's a reason why people tend to do this, collect this data over a extended period of time, because you can have fluctuations. And as important as this topic is to all of you all, suicide is a relatively rare behavior. And so because of that, it's what we call a low base behavior. Then 2 or 3 more cases can really elevate the percentages. And so we like to look and see if we see a pattern over time. Having said that, however, the things that typically create stress, job insecurity, housing insecurity, food insecurity, which I talked about earlier, and the simultaneous decrease in social connectedness, does really concern me. Because one, these risk factors disproportionately affect communities of color and the LGBTQ youth. We've been working with LGBTQ youth who are in college right now. Many of them have had to leave an affirming space at school and move back to non-supportive spaces at home. The students that I work with, I call it finding your tribe. Many of them found their tribe finally in college and feel very comfortable and have created another family almost at the university, and that has been abruptly taken away. And they may not be able to openly connect with their tribe, even online, because their parents they may not be out to their parents, or if they are out to their parents or their family is not supportive of their sexual orientation or their gender identity expression. And so those students are kind of caught in a quagmire right now of experiencing all of the risk factors and an elevation of those while simultaneously losing some of the protective factors. We also know that calls to crisis centers and hotlines have gone up 800%, but males who have the highest risk for completing suicide, and many students or young people from communities of color don't typically use hotlines. So it's a challenge, and we have to figure out what are ways that we can make hotlines more accessible or more palatable or more culturally congruent with those communities. And then we also know that economic downturns, which we're in right now because of COVID-19, does typically, not always, but does typically lead to suicide increases. The most recent example being the economic recession of 2008. We also know in the adult research that race-related stress is a powerful risk factor, a more powerful risk factor than stressful life events for psychological distress. And some people have asked me, is it traumatizing to view these videos over and over again? And I think it is. I don't know who put this together, but someone put together a videotape of all of the mostly young African American men who've been killed recently by police officers. And by the time you see the third one, it was traumatizing to me. And so I wrote the person a note and said, please don't pass this on, because I know you're trying to make people socially aware, but there are ways to do that without traumatizing people with images that are very distressful. Also, I would share with my church members and with clients, sometimes you need to take a break from the media and kind of step back from it for a while, because it can be traumatizing to experience this over and over and over again. All right, I'm going to talk a little bit about treatment engagement. There are definitely differences, racial and ethnic disparities in the use of mental health treatment, which in part is due to structural barriers and social determinants of health. So the rates of engagement in treatment and treatment completion are much lower in Black adolescents compared to white adolescents. Some of that may be due to negative perceptions of systems of services. Providers also not being confident in providers. And then I said earlier, there's sometimes a reluctance to acknowledge symptoms. Black youth are less likely to receive outpatient treatment, even when you take account other variables that place them at risk for suicide. And Black youth are less likely to receive care for depressive symptoms and suicide. Another barrier is that community norms don't typically support seeking professional mental health treatment. And this is something I talk about a lot with people in my church, people that I do talks with. I remember once my oldest daughter was pregnant, we were in a store and I was talking to this young woman in a grocery store, and she was telling me about several people in her family were depressed and had attempted suicide. She was crying in the store. And so I was writing on a piece of paper to give her a referral, and she got angry with me and said, you're trying to say I'm crazy? I don't need any professional help. And I said to her, you have a strong family history of people with depression and have made suicide attempts. You're talking to me right now, you're distraught in the store. This is not saying you're crazy. This is saying that you need some support. So some of what we have to work on is changing community norms about the fallacy that Black people are strong and resilient and never need help. Or people will talk about our ancestors didn't have to go to psychologists. Our ancestors didn't go to psychologists because that wasn't available to them. Doesn't mean that they didn't need the help. My grandmother had 16 children, and my mom and my aunts will often say, well, mother she wasn't stressed out. And I was like, and when my grandmother was born in the turn of the 20th century, people didn't talk openly about mental health concerns. So if you have 16 kids, I'm sure you felt stressed out sometime, but her cultural norms didn't really allow her to express that. We also know that many LGBTQ youth don't seek treatment because they're concerned about needing parental permission. Lots of my students on campus will not go to seek help because they're afraid that the bills, the insurance bills, will go back to their parents. They don't want their parents to know that they've been in treatment. Affordability of care is a problem. For transgender and non-binary youth, they're concerned about receiving competent mental health care from providers who may not be sensitized to or have training in providing services to this community. And also, there's some concerns with mental health professionals trying to get them to change their orientation or gender identity. There have been several states which now ban sexual reorientation therapies, but that's not true every state. And about 10 to 15% of LGBTQ youth will say they've had someone, not necessarily a mental health professional, but someone has tried to talk them into engaging in sexual reorientation therapy. The other public health challenge is that in the Black and Latinx communities, the suicide rates are highest amongst Black youth and Latino youth, and those communities are disproportionately young, which means they are more impacted by the suicides. So we need to identify culturally salient and risk and protective factors at the individual, family, and community level. We need to develop culturally sensitive interventions, and we need to develop programs within institutions and communities to increase sustainability. So my dog is trying to get into the room. She's scratching and scratching and scratching. So give me 1 second, let me let her in. Sorry about that. This is the equivalent of the cat walking across the screen, but she's gonna start barking in a second, so I wanna spare you that. Okay, so it's important to look at treatment engagement. Oops. Okay, so it's important to look at treatment engagement because the barriers to treatment may not be unique for youth from communities of color or for sexual minority youth, but there are cultural nuances that create barriers to treatment engagement. For example, Blacks are reported to have significantly more stigmatized attitudes towards depression treatment, don't feel comfortable with, or feel more comfortable is another way of saying it, with going to faith-based supports, and also concerned by the lack of cultural relevance to treatment. And I have one of my graduate students who did a study with Asian American college students, and she found that those who were acculturated were more likely to have positive attitudes about treatment, but those who were inculturated, who embraced more their culture of origin, are less likely to have positive attitudes towards treatment seeking for mental health. So these are students who are on college campuses where mental health care is relatively accessible, and they still don't feel comfortable with going. So it's not just having clinics nearby or facilities nearby, it's also having cultural norms which will promote you seeking help in those resources. Why don't we know more about suicide in youth of color? Some of that's the assumption of universality. There's an assumption that depression looks the same in everybody, although we know that that's not true. We know that in Asian communities, Black communities, more likely to express somatic complaints or body aches and pains rather than talk about feeling sad or blue. Very few interventions have shown to be effective for racial ethnic groups. Now, this doesn't mean that they're not effective. It means that no one's done the research. So youth from communities of color are often not identified in research samples, or they're not included in the studies, or there's not enough of them in the study to analyze treatment outcomes by race. There's also, unfortunately, disparity in funding for researchers from community of color, and that's important because researchers from communities of color are more likely to do this research. In a recent review, Black investigators were half as likely to receive NIH funding when compared to white investigators. And why is that a problem again? Because white investigators are less likely to do suicide research about people from communities of color or sexual minority youth. So it's important to have representation in those communities amongst the researchers themselves. So what can we do to help children not just survive, but thrive? What can we do to minimize or eliminate risk factors, enhance protective factors? And I want you to notice I'm focusing again at the community level, the family level, and the individual level. Most of our treatments focus on the individual level, but that's not going to be enough because children are embedded in a family, and the family is embedded in a community, which is embedded in a broader society. And so we need to have interventions aimed at all 4 levels. So one of the examples I'm going to propose is not the only one. And I want to stress that too, because just like doing interventions in schools by themselves isn't going to work, doing them in faith communities by themselves isn't going to work either. We need multiple approaches and multiple ways at getting at kids so that we can help them have a more optimal life. So the Black church is one avenue that I'm proposing because it's one of the most influential institutions within the Black American community. 87% of Black Americans are affiliated with the church. Over 60% of Black youth attend the church regularly. Also, of that 87% who are affiliated, most of them are women. And guess who decides whether or not a child goes to church? Moms. So it's a really good place to get kids, even if they're not members of the church, because churches also like to do a lot of outreach with youth, so they can help youth in the community who are not members of the church. Why include faith communities? Mental health issues affect people across all faith traditions. Faith leaders are often first responders. And so, as I said earlier, family members in particular are probably more likely to go to clergy persons than they are to go to a mental health professional. That's how I got involved in this research to begin with, because I was very struck by the fact that people would come see me in church and would not come see me in my office. Faith communities care for whole persons in the family. They interact with people in diverse settings. Congregations include people from diverse workplaces, including mental health professionals. I've been fortunate to be involved in starting 3 different counseling programs or therapy programs in churches. We have a program in my own church now. I developed one in a Baptist church, which had about 1,500 members. And I was part of a team that developed a pastoral counseling center, which was located outside the church. Wow. We serviced about 3,000 people, and it was about 20 practitioners. And then also mental health crises are also crises of faith. But there are barriers to seeking help in faith communities. Sometimes people believe that suicide violates the community's cultural norms or values. Sometimes people think of mental illness as a sin or a moral failing. They think that suicide reflects a lack of faith or weak faith. Also culturally, I still hear people saying suicide is something that white people do and Black people don't do. And that's not true. There's stigma associated with mental illness, and there's stigma associated with being a member of the LGBTQ community. But the good news, things are changing. There's less stigma associated with suicide. Many faith communities now focus more on looking at levels of competency and not around the issue of sin or not sin. Mental illness is more likely to be seen now as like any other disease, and it's not a reason for shame or guilt or a sign of a deity's disapproval. The silence is being broken by clergy, and clergy more and more are seeing themselves as developing partnerships with mental health professionals, and people have more open and affirming churches. This lower picture is actually my church, and we were having a family game. So we had a quick service that morning, and then around 12 noon, we invited people in the community, and we did it in the sanctuary. I have a small church. We did it in the sanctuary. People played games. You can see the rainbow flag kind of there in the background, and we have a sign that's up that talks about us being an open and affirming church. We have a huge rainbow flag outside the church. So there are affirming, not a lot, but there are affirming predominantly Black churches. This is just some more of the campaigns. These are all from my church. So this is, every year I do a Bible study on sexuality in the church, and this was what I did, I think, 2 years ago, LGBTQ. We Are All Family, right? And it's an 8-part series which talks about sexuality in the church. Every year we do the Faith, Hope, and Life campaign that's sponsored by the Action Alliance Against Suicide Prevention, or for Suicide Prevention. This is a signage in our church that uses the rainbow flag and talks about be the church and we reject racism, etc. This lower on my right, for Juneteenth, because we're in the quarantine, you see we have on our mask. This is my church in the background. We did a protest movement outside the church, Black Lives Matter. Our church is located on a really big highway. And it was such a powerful moment because we had so many people honking their horns and stopping and waving, hundreds and hundreds of people on this highway, just because we were out there for 2 hours with this sign. And then each year my church has a theme. This year our theme happened to be relationship, not religion. And we did a 4-part series on that about the focuses on being connected and not sort of being quote unquote holy and engaging in quote unquote pious behavior, but really focusing on how we connect with the deity, but also how we connect with each other. It's interesting, this fits really well with the pandemic, although at the time that we developed this series, we didn't know that was going to be happening. So it fosters a sense of community, that what we talked about earlier, mattering and connectedness. This is really, really important during the pandemic. There are still things that you can do now, even in the midst of the pandemic, which requires social isolating. My church, we actually meet more now. So we have our worship service on Zoom. We have a weekly stress management session where I do mindfulness and stress management and relaxation with them. We have a book club. We have Bible study. We have social hours. And so we do a lot of things to make sure that people stay connected. We have people who are used to check in on people we haven't heard from for a while. Our church is a relatively younger church, and so people are pretty tech savvy and can use Zoom. But we have a couple people who aren't as comfortable, so we've gone by and helped them, showed them how, or directed them to videos online of how to do a Zoom meeting. There are educational opportunities, so there's workshops on environmental justice, which is what one of these my church is known for, conferences on suicide and the Bible study series on depression and suicide, sexual identity, and queer theology. I've done all of those. This is us at our Juneteenth protest, which I just talked about earlier. I love this picture. This is our youngest member. He just turned 1. He has on his Black Lives Matters t-shirt. This is me with my oldest granddaughter talking about Black Lives Matter. This is my youngest daughter, who is a member of the queer community, and she also wanted to do the rainbow signage to say all Black Lives Matter, including trans, LGBTQ lives matter. So one of the nice things about doing interventions in a faith community is that there are narratives of hope. People have their hopeful stories from their history and their ancestry about how people have overcome adversity in the past and finding meaning in life's hardships. I said earlier, this is the National Weekend of Prayer for Faith, Hope, and Life, which happens every year in May. So hopefully you can talk to your faith community about this, joining us next year. And so in conclusion, it takes a village. It's going to take all of us. One setting is not going to be the answer for everyone, but a faith community is one setting in which you could do interventions. You could do them in other community settings. You can do them in schools. It's just trying to figure out what's the place or the space that's going to make the most difference. So thank you.
Awesome. Thank you so much, Dr. Sherry. We really
I'm laughing at Grace Terry.
I see her. She's awesome. And thank you so much. I think at this time we wanted to open the floor for questions.
Sure.
If anyone had a question. I see Grace.
Yes, thank you so much. This is
welcome.
This has been awesome. I can't wait to share all this great information with my network. And for people who don't know, this is American Sign Language for applause. Okay. So the question I had, Dr. Sherry, is this. That I was really struck by that 800% increase in calls to suicide prevention hotlines.
Right, yeah.
But do you know during what time period that is, that 800% increase since COVID?
I think it's the first part of June.
Starting when?
That's over a month. So that's probably the month of May.
Okay, but the statistic of the 800% increase, is that from like January to?
No, that's from like, I'm going to have to look up to be sure, but it's a month. So it's like April 15th to May 15th. It's a very scary, yes.
Over last year, you're saying?
Yes.
I got it.
They pick a finite point and they compare to the year before. We're actually looking at Healthy Minds Survey, which is a national survey that goes out to college students. And we're literally just analyzing this data as I'm speaking. So y'all be quiet because we haven't published it yet. But we're seeing anxiety rates like 40 and 50% in LGBTQ youth. So depression, 60%.
Right.
This is like clinical depression. 60%.
Right. Right. Increase over last year.
Yeah, so this is, I'm very concerned because I think, and my school is one of them, people are very concerned about opening in this fall and the money that was lost. And I realize that without revenue, you can't operate. But what's missing in all these conversations is what about the mental health care?
Thank you. Thank
One
you.
of the students have on-site mental health care. At George Washington, we have 4 clinics just for mental health alone. So what's going to happen, particularly to the more vulnerable students like the LGBTQ students who may not be able to access those services at home, who also may be in more stressful environments at home. And so, we're talking about this amongst ourselves. I was saying at our last faculty meeting, we really need to talk to a dean and the president about this, because talking about this amongst ourselves is not, we're the choir. That's not going to help this.
Right.
We need some kind of mechanisms to support these students while they're home.
Yes. Yes. Thank you so much. Thank you for all the good you do all the time. I wonder, would you be willing to post your contact information?
Sure, I can do that. Yeah, I'll put it in the chat.
Thank you so much.
You're welcome.
And Dr. Sherry, we also have one more question from Annie Connors. She wanted to know, what is the website for your conference in May again?
It's not a conference, it's a prayer, it's a weekend of prayer. So let me see if I can figure out how to get you that while we're talking.
No problem. No problem.
It's prayfaithhopelife.org. I wrote it down. Is that what we're talking?
Probably.
Prayfaithhopelife.org.
Awesome. Okay, and I will double check that and make sure we put that. Oh, perfect. It's in the chat on the corner there. So
I just stuck it in there, yeah.
Thank you so much. And I did see that Greg made a statement during the presentation that there was a bill in the last session of Georgia General Assembly to prohibit conversation therapy for youth 18 and under.
Right.
However, it did not pass, which
Right.
is with the House. So that was interesting. Thank you for sharing that, Greg. I greatly appreciate it.
Yeah, so every state has to do this, has to decide on this. So in the southern states, people are more likely to engage in reorientation therapy and are less likely to want to ban it completely. I live in Maryland, so it's been banned here for a little while. This is a really sensitive area, so let me share this with you. There is no scientific evidence that sexual reorientation therapy works. It is true that it will change behavior. What it does not do is change orientation. So this is actually a midterm question in my graduate class. If a client comes to you and says they want sexual reorientation therapy, what is your response? And the controversy is this. I believe that people are autonomous adults and they can make their own decision. So I don't think it's appropriate for us to decide for them what they can and cannot have, but I do think it's important to convey all the information to them. So what we train our students to say is, there's no scientific evidence that this works. We don't do this therapy and we're not going to do this therapy. We think the therapy is harmful. However, are there people out there who will do the therapy? Yes, they are. Will we direct you to them? No, because ethically we can't do something that we believe is harmful. But if you want to look this up yourself, you could. So our job is to present the evidence to them, and then they can make their own decision. The issue about under 18 is because the theory is that they're not old enough to legally consent, therefore they're not old enough to make that decision of to do something that might be harmful or not, and that's the issue there.
Thank you for expounding on that, Dr. Sherry.
Question.
No problem. Is there anyone else that has any questions that they would we have a little bit more time, so we're open to any more questions if there are any. I don't see anything.
Ziamara, I was just going to say too that if anybody wants to sign up as a member of V4P to get our suicide prevention emails, you can go to our website, v4p.org, and you can get legislative updates and a lot of other great information.
Thank you so much, Greg. I greatly appreciate that. And I'm actually going to put that in the chat box for all attendees. So whenever you get a chance, you guys can see that, but it will be in the chat there. And I actually had one quick question for you, Dr. Sherry. During COVID right now, it is high stress, high anxiety. Is there anything that you can provide for us right now that maybe would be a good activity to do with our community, or something that can help relieve some of that anxiety and thoughts coming in? Is there anything that you could suggest or you've seen work?
So, ironically, believe it or not, one of the things I want to talk about, this is an indirect way of answering your question, is that you guys put your mask on first. And what I mean by that is take care of yourself. I think as caregivers, you're probably stressed up to here. That there are a lot of people pulling on you and asking you questions and wanting help from you. And to get comfortable with telling people we don't know, because we don't. I've had to say this to my students all the time, like, what's going to happen? You know, particularly doctoral students, some of them are trying to graduate. They're like, am I going to find a job? I spent the last 6-7 years of my life working for this Ph.D. and now I don't have a job. Can we get licensed? Because their training hours got cut. So now they don't technically meet the licensing hours for some states. All of that. And so for all of that, what I have to say to them is, I don't know. But what I do know is that we always advocate for you. We will be continuing to advocate for you. So maybe some states will have to change the criteria, because we're all in this together. So you're not the only person going through that. That's fine. So make sure you all engage in self-care and take good care of yourself so that you can be replenished and you can help other people. And having said that, really try to figure out ways to keep people connected, particularly your most vulnerable clients. So if you have clients who you know easily fall through the cracks, those are the ones that you have to be the most diligent about. If there are ways in your agencies where you can delegate some other tasks, let's say administrative tasks, to other people so you can focus a little bit more on the clinical work right now, do that. I think in our church, we have 60 members, and I can't, even though that's a small number relative to other churches, I can't personally follow 60 people. And so I have referred people out. I have developed buddy systems for some people. We have, I do IM people, I Instagram people, I tweet people, whatever way I can do to make sure they know I got you. And sometimes that's all people need to know. I think we need to realize that in this moment in time, we can't fix everything. For example, everyone's looking for a job right now, so you may not have a job for somebody. But are there other things you can do? Are there things you can help with clothing? Are there things that you can help with food? Can you help direct people to agencies that can help them with unemployment benefits? Are there agencies you can help them, direct them to around their housing? And I don't know about in Georgia, but in Maryland right now, legally, you cannot evict anybody right now. Mm-hmm. Our governor had the foresight to extend this to the end of the year. So that gives people a reprieve, right? He was very wise. He's doing because part of the anxiety is people keep changing the deadline dates, right? So it's easier to say December and pull back in than to say October, November, and then every month their anxiety is going up and down. So I just pick a date out there, and then we can work towards coming back in from that day. So those are, and I know some of you may feel like I'm not a social worker, it's not my job, but what I tell my students, our job is to help people be healthy. So sometimes we have to wear other hats. So no, I'm not a social worker, but I know social workers. I make sure I keep knowing social workers, because what I know they know the stuff that I don't know. So take the team. And you don't have to be the only person that knows everything. So use your team. Our church uses social work probably more than me, because we have a lot of homeless youth cross our path. Mm-hmm. And I love that my church members bring these people too. I mean, literally my church members will bring people off the street and say, this person's homeless. And in that moment, if we can't do it ourselves, we know who to call. We will call people on a Sunday morning and say, hi, so-and-so's here. We'll ask where do you live? What services are available in that area. And they do that in their sleep. So I don't have to keep looking up stuff and trying to figure things out that they already know how to do. At the same token, if someone needs a suicide risk assessment, I'm your girl. I know how to do that in my sleep. And so And the difference is because it's my expertise, I'm not afraid. So we can't ask people to develop expertise in a moment that they're not used to doing. So really try to build a resource directories is what we use.
I like that.
And we teach churches how to do that. So you have these numbers and names at your fingertips. And then network, we don't try to do everything by ourselves. We network with other churches in our community. I network with other colleagues. I have a list, literally, I'll show it to you all. It's 3 pages long. These are provider names that was by my computer. And so when people call, I go, oh, okay, I don't have to look for something. It's like right here, because I know people are going to call about housing and food. And we're already working a program called Share, which distributes food to people. Someone just called me yesterday and told me about a church in DC that is distributing food for DC residents. So I send that information out through our through email, and I text that information out. Also, I hate to say it, but figure out how to use technology efficiently. So I know now how to send something through email and change that into a text message. And I do, something that's easy so I can get it to my church members in different ways. Some of them are on Facebook, and then like I do that. So I'm 63, but I learned how to do all of it because the people in my congregation are younger and they know how to do all that stuff. So, the Bible says, Paul became whoever he had to become to serve the people. So sometimes you have to do that.
Oh, well, thank you so much again, Dr. Sherry. You gave us amazing information that I'm pretty sure we all are grateful to receive today. I see still a little bit of questions. Unfortunately, we are running out of time to answer everything. But what I did want to state that is I will be putting all of the resources that we discussed today on the V4P website, and which I did place in the chat, which is www.v4pga.org. And I will be getting all the information from Dr. Sherry to make sure it's all of her contact information and events that she may be having will be present on our website as well. So if you guys did want to reach out or attend, you would have that access as well. And just a reminder, the V4P member call, the next V4P member call will be August 20th. So we are looking forward to that as well. So once again, I just want to thank everyone for coming. I believe that we received amazing information. Once again, we couldn't have done this without you, Dr. Molock. It was amazing. And just everyone, make sure that you go to the website to get all the information. We will be placing the slides that Dr. Sherry used today on the website, so you can go back and review that information, because she did give us a lot that I know a lot of people want to go back and read up on. So that would be great.
The CDC information and the Trevor Project data is on there. Please download that, because you can use it in your own presentations, and it's just great information to pass out to your clients as well.
Perfect. Oh, well, thank you again, everyone. It was a great evening, and I hope everyone has a blessed day. And thank you for attending today.
Thank you so much for having me, and take care and be safe.
No problem. Take care, everyone.